Another area where we need to see that there is no leak is when between the external ear canal and the specula. If we apply pressure in the external ear and there is a leak, we will not be able to see the correct movement of the tympanic membrane. This may make us overlook a middle ear effusion. For this reason, it is very important to use the largest oral specula to obtain a good seal between the speculum and the external canal. If there is a leak present, what we need to do is apply a gentle tragal pressure to achieve an airtight seal around the speculum. We also need to correctly hold the otoscope and the bulb. In the next slide, we will show you a picture on how to do that. It's also important that we compress the pneumatic bulb and then we insert the oral speculum into the ear canal. This helps us build a negative pressure and we will be able to see the hypermobility more easily. This will help us distinguish the adhesive otitis media and if there is a perforation, and also when we see the retracted tympanic membrane. The bulb should be compressed gently, not firmly, because that will make the difference in the movement of the tympanic membrane. The negative pressure is followed by positive pressure, and this is repeated several times to be able to see the correct movement of the tympanic membrane. Here is a picture showing how to hold the otoscope with the bulb. Though the presentation here kind of explains completely what I needed to explain about pneumatic otoscopy, but I couldn't move ahead without giving you some general idea of the otoscopic technique, because this would be the first thing that we would do to figure out acute otitis media. We would definitely do the general exam, that is check the whole ear and see if check the pinna, the postaurical skin and other things. We must check both ears, the normal ear being examined first, because we want to be able to see any normal anatomical variations for that particular patient. We must see that the ear canal is clear, because sometimes there is wax, and when we try to see the tympanic membrane through that wax, we are not able to get a clear picture. When examining a child, we must immobilize the child, because if we do not do that, the child may move and the child may get hurt. We always use the right hand to check the right ear and the left hand to check the left ear. Of course, the size of the specula, as we have mentioned earlier, should be as large as possible that would fit the ear. Here is the correct way of holding the otoscope. We hold it between the thumb and our first two fingers, seeing that our little finger is connected with the child's face, because if we do that, then if the child moves, then the finger is going to act as a fulcrum and will move with the face, and thus less chances of the child being hurt. Here we can see the little finger acting as a fulcrum. The specula should be gently inserted into the external ear. The external ear is crooked. To straighten the canal, we use the free hand to gently pull the pinna outwards and downwards in the infants and upwards and posteriorly in the older children and adults. Also, our external auditory canal has hair in the 1/3 outer part, and that's the area which is not very sensitive, and also then the two-third inside area does not have hair and it is very sensitive. We should try and put the specula only in the one-third outer area. In assessing the tympanic membrane, we check the color, opacity, position, mobility, and the landmarks. For the color, it could be yellow, red, or white. For the yellow, it usually represents serous fluid behind the tympanic membrane and suggests otitis media with effusion. Red, it could be because the child is crying, or it could suggest acute otitis media. White plaques could represent tympanosclerosis. Opacity, if it is translucent, it usually represents a normal tympanic membrane. A transparent tympanic membrane is typically a very atrophic tympanic membrane. And if it is opaque, it usually represents otitis media. If we are able to see some bubbles behind the tympanic membrane, it usually represents middle ear effusion. Position of the tympanic membrane, it could be bulging or retracting or normal. If it represents bulging, usually represents acute otitis media, and the retraction suggests eustachian tube dysfunction or middle ear mucosal dysfunction. Mobility could be increased or decreased or absent. Increased mobility represents eustachian tube dysfunction, decrease represents middle ear effusion, and absence is usually due to the adhesive otitis media or large perforation. Last but not the least, we check for the landmarks and assess the tympanic membrane. Here we are looking at a normal tympanic membrane, which is pinkish green color. It's fairly translucent. When we are looking at the tympanic membrane, we will check for the pars flaccida, anterior malar fold, lateral process malleus, posterior malar fold, malleus handle, and pars tensa. Here is an example of otitis media with effusion. Atrophic tympanic membrane. We can see all the parts very clearly in this case. Here is an example of perforation. Here is a website which gives really great case studies. We should all take a look at these.